Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn, medical editor at MIMS Learning. Joining me in the studio today is Sangeeta, another medical editor at MIMS Learning.
Hello.
So today I thought we would talk about diabetes. Now at the time of recording, NICE have just published their revised type 2 guidance. And there has been a major change. So now people who are newly diagnosed with diabetes should be offered an SGLT2 inhibitor as well as metformin. And those with established cardiovascular disease should receive the GLP-1 agonist semaglutide as well as an SGLT2 inhibitor and metformin. We are in the process of updating our module on the guideline. However, we do have a lot of content on diabetes that we can discuss in the meantime, so let's have a look at those.
Before we do, I think we should discuss the different types of this condition. So while the most common are type 1 and type 2 diabetes, 2% of people with diabetes will have a different type. Many of these patients will be misdiagnosed as having a more common type of diabetes, which can lead to treatment delays. For example, we have this case study on latent autoimmune diabetes in adults, or LADA, by Dr. Pipin Singh. In the case study, he looks at how LADA can be confused with type 2 diabetes, and he also looks at when to suspect that a person with type 2 diabetes might actually have LADA. So according to Diabetes UK, LADA is a cross between type 1 and type 2 diabetes, which is why it's sometimes called type 1.5 diabetes.
Yeah, and there's also type 3C diabetes, and like LADA, it can be confused with type 2 diabetes. In fact, up to 20% of people with type 2 diabetes might actually have type 3C diabetes. And as a reminder, type 3C diabetes occurs as a result of damage to the pancreas. I actually spoke to GP Dr. Patrick Holmes about identifying and managing type 3C diabetes in primary care for this podcast. So I will leave a link to that episode in the show notes. And just to mention as well, there's an ongoing campaign for Lila's Law in memory of Lila's story. Lila was a 2-year-old girl who died of diabetic ketoacidosis after her GP misdiagnosed the signs and symptoms of type 1 diabetes as acute tonsillitis. The campaign is calling for a new law to ensure babies and children are routinely tested for type 1 diabetes as part of medical assessment. For more information about the campaign, see the show notes. But given that 90% of people with diabetes will have type 2, let's focus on that type for now. Sangeeta, remind us, when should GP suspect type 2 diabetes?
NICE states that type 2 diabetes should be suspected in adults with persistent hyperglycemia that may be accompanied by clinical features such as polydipsia. Persistent hyperglycemia refers to an HbA1c of 48 millimole per mole or more, a fasting plasma glucose level of 7 millimoles per liter or more, and a random plasma glucose of 11.1 millimoles per liter or more in the presence of symptoms or signs of diabetes. Now, if a person is symptomatic, a single abnormal HbA1c or fasting plasma glucose is enough to diagnose type 2 diabetes. But if the person is asymptomatic, repeat testing, preferably with the same test, should be used to confirm the diagnosis.
Okay, so you're referring to adults there, but exactly how old the adult is relevant. If they are younger than 40 years, they have young onset type 2 diabetes. Now, I was kind of miffed that I'm now too old at 45 to have young onset type 2 diabetes, but obviously you don't want type 2 diabetes and you really don't want young onset type 2 diabetes. In our module on young onset type 2 diabetes, Dr. Sandhya Raman writes that the condition is associated with a worse prognosis than type 2 diabetes of typical onset. This is in part because of the longer duration of metabolic dysfunction and hyperglycemia in patients with young onset type 2 diabetes. Presumably, because of these worse outcomes, in the updated guideline, NICE now recommends triple therapy consisting of a GLP-1 medication, metformin, and an SGLT2 inhibitor, rather than dual therapy for newly diagnosed patients. The caveat being is that if the patient is under 16 years, specialist advice should be sought.
Type 2 diabetes is a risk factor for several conditions, including cardiovascular disease, as we all know, which is why the new guidelines have been broadly welcomed. They focus on reducing the risks associated with diabetes. But before we talk about the conditions that diabetes can lead to, shall we talk about the risk factors for diabetes? Obviously, the first one that comes to mind is excess weight. And regular listeners of this podcast will know MIMS Learning is running a campaign on obesity at the moment, Confidence in Obesity Care, which seeks to enable GPs and other primary healthcare professionals to support people living with obesity more confidently. The campaign features CPD modules from podcasts to in depth clinical reviews on managing obesity and its related conditions like diabetes.
Yes, obesity is definitely a risk factor, but we should keep in mind there are other risk factors as well. There's increasing age, having a parent, sibling, or child with diabetes, and a history of hypertension can all increase your risk of developing diabetes. And ethnicity can also be a risk factor. You are 2 to 4 times more likely to develop type 2 diabetes if you are of South Asian, African, Caribbean, or Black African descent, according to Diabetes UK. And actually, the age at which your risk of diabetes increases depends on your ethnicity. If you are white, your risk starts to increase at age 40 years. But if you are African Caribbean, Black African, Chinese, or South Asian, your risk starts to increase at 25 years.
Yes, as a South Asian myself, I'm quite acutely aware of being at a higher risk of diabetes and at an earlier age. And I think being aware of this really helps because then you can adopt lifestyle measures to reduce this risk. Not only do people from these ethnicities tend to be diagnosed with type 2 diabetes at a younger age than those who are white, they also experience a steeper decline towards beta cell failure and they experience more frequent diabetic complications with a greater morbidity and mortality. Dr. Raman, who wrote the module on young onset type 2 diabetes, has written another module on type 2 diabetes in South Asian and African Caribbean populations. She notes that reasons why these populations develop type 2 diabetes at an earlier age and have poorer outcomes are complex, but comprise an intersection between epigenetic risk, body composition, socioeconomic factors, and variability in medical management.
Dr. Raman observes that one of the reasons for the poorer outcomes is that some GPs do not understand that the risks associated with excess weight, including type 2 diabetes, start at a lower BMI in South Asian and Afro-Caribbean populations than they do in white populations. So there are missed opportunities to identify risk. Dr. Raman adds that not providing cultural specific advice on lifestyle modification is another missed opportunity. She spoke to me a couple of years ago on this podcast about the need for culturally appropriate lifestyle advice. And one of the things she said was that people from South Asian backgrounds are more likely to be cooking from scratch than people from white backgrounds. So perhaps they don't need to be advised against eating ultra-processed food. However, they are more likely to use the wrong types of fat to cook food. So that needs to be borne in mind when giving lifestyle advice.
Yeah, I totally agree with this. South Asians definitely tend to eat less ultra processed food, in my experience, but they are more likely to have more oil. I'm thinking of all the deep frying in oil and ghee. So, individualized patient care, if time allows for it, is always important. Shall we move on to the complications of diabetes? I think both cardiovascular disease and chronic kidney disease or CKD are associated with diabetes. In fact, there's been a lot of discussion about cardio-renal-metabolic disease or CVRM disease. This refers to the intertwined pathophysiological relationship between cardiovascular, renal, and metabolic conditions like diabetes or obesity. In his module on CVRM disease, Dr. Holmes writes that patients often progress from possessing borderline risk factors such as mild hypertension or impaired glucose tolerance to overt disease, including myocardial infarction, heart failure, and advanced CKD. He adds that identifying and interrupting this progression early is central to effective clinical management. There is currently no specific NICE guideline on CVRM disease, but if you look at the NICE guidelines for type 2 diabetes, heart failure, and chronic kidney disease, there is an overlap in terms of the medications that are recommended. For example, SGLT2 inhibitors are now first-line options for heart failure and for type 2 diabetes. They are also an adjunctive therapy for people with CKD.
We should point out that we have some great content on managing diabetes and chronic kidney disease, including a 3-part podcast with nephrologist Dr. Andrew Frankel. So we will leave a link to those resources in the show notes. Okay, so yes, both heart disease and kidney disease are major complications of diabetes, but they are far from the only ones. We have a module on the skin conditions related to diabetes by Dr. Angelica Razak. She says there are 4 main types, and these are skin infections, foot ulcerations, skin complications resulting from hypoglycemics, and skin disease associated with diabetes. Sangeeta, you were just talking about SGLT2 inhibitors there. What does Dr. Razak say about these?
Dr. Razak says that SGLT2 inhibitors have been associated with an increased risk of genital fungal infections as well as Fournier's gangrene, a necrotizing fasciitis of the genital and perineal areas, fixed drug eruptions, drug-induced pruritus without any skin signs, and sweet syndrome can also occur with SGLT2 inhibitors. Dr. Razak also notes that GLP-1 agonists, aka weight loss medications, have been associated with alteration of skin sensation such as dysesthesia, hyperesthesia, allodynia, and paresthesia. Though, of course, the risk of these complications is quite low, and fundamentally, the benefits of SGLT2 inhibitors and GLP-1 agonists likely outweigh the risk of any side effects for most patients. Do take a look at our sister site MIMS because, of course, that has comprehensive information on the potential contraindications, warnings, interactions, and adverse effects for these and many more medications.
Right, so that's skin conditions associated with certain hypoglycemics. I'm not going to go into the diabetes-related skin conditions because we could be here all day. Dr. Razak mentions at least 20. So I'm going to suggest that listeners have a look at the module because it's so comprehensive, I don't think we can do it justice. But I do want to mention foot ulcers because this is a major concern in diabetes. Dr. Razak comments that diabetic foot ulcerations occur in up to 10% of patients with diabetes and are caused by neuropathic and vasculopathic complications, diabetic foot syndrome, as well as by high mechanical pressure because of ill-fitting footwear, foot deformities and arthritis. But this is more than just having a sore foot. Ulcers can cause serious problems. Superinfections of diabetic foot ulcers can lead to osteomyelitis and sepsis, and in the worst case scenarios, amputation or even death. Therefore, an intensive care provision through a dedicated diabetic foot clinic is indicated.
That is a good point, but we shouldn't dismiss pain as that can have a major effect on the quality of life. We have a module on painful diabetic neuropathy by Dr. Mick Seppel, who defines it as pain as a direct consequence of abnormalities in the peripheral somatosensory system in people with diabetes. People with PDN often describe the pain as prickling, burning, deep aching, sharp, stabbing, or an electric sensation. Dr. Seppel notes that the 3 pillars in the management of diabetic polyneuropathy are glycemic control, foot care, and symptomatic pain management. He adds that there is strong evidence that in people with type 1 diabetes, enhanced glucose control significantly reduces the risk or delays the development of neuropathy. However, the evidence for the benefits of glucose control in type 2 diabetes is not as strong, even though type 2 diabetes is the more frequent cause of neuropathy. Additionally, aggressive glycemic control, if it is achieved too quickly and the targets are too low, significantly increases the risk of severe hyperglycemia, and this in turn can lead to treatment-induced neuropathy.
So we have now talked about the cardiovascular, kidney, skin, foot and pain complications of diabetes. We do have a dedicated learning plan on these complications featuring some of the modules we've mentioned today, so do take a look. Other complications include retinopathy and gum disease. That diabetes can lead to so many things is why GPs are broadly happy with the new type 2 diabetes guidelines. When the draft guidelines came out, advanced nurse practitioner Bev Bostock told MIMS that the new recommendations brought us closer than ever to an evidence-based approach to managing diabetes with a strong focus on preventing or reducing the impact of complications. Recap time. What have we learnt? Diabetes is a complicated condition that can take many different forms. While the most common types are type 1 and type 2, 2% of people with diabetes will have a different type. Many of these patients will be misdiagnosed as having a more common type of diabetes, which can lead to treatment delays. Both LADA and type 3C diabetes can be confused with type 2 diabetes. Obesity is a major risk factor for diabetes, but age, genetics and ethnicity can also play a role. You are 2 to 4 times more likely to develop type 2 diabetes if you are of South Asian, Afro-Caribbean or Black African descent, according to Diabetes UK, and the age at which your risk increases does depend on your ethnicity. If you are white, your risk starts at age 40 years, but if you are African Caribbean, Black African, Chinese or South Asian, your risk starts at 25 years. And diabetes can lead to multiple complications, including cardiovascular disease, kidney disease, skin conditions, foot ulcers and pain. The update to the type 2 diabetes guidance has broadly been welcomed because the move to recommend SGLT2 inhibitors as a first-line therapy alongside metformin represents a move towards preventing the complications of diabetes as well as glycaemic control. Thanks, Sangeeta, for joining me today, and thanks to our listeners for joining us. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Don't forget, you can claim a CPD certificate for listening to this episode. Simply head over to our website version at mimslearning.co.uk. Join us next week for more comprehensive clinical education.